Welcome to Pediatric Podcast for PedsCases.com.
Welcome to Approach to Pigmented, Cutaneous, and Ocular Lesions and Melanoma, a podcast made for PedsCases.com at the University of Alberta.
I'm Dr. Harry Liu, a dermatology resident at the University of British Columbia.
And I'm Jennifer Ling, a fourth-year medical student at the University of British Columbia. This podcast will provide an organized approach to understand pigmented, cutaneous, and ocular lesions and melanoma. We would like to thank Dr. Miriam Weinstein and Dr. Connor Mulholland for developing this podcast with us. Dr. Weinstein is a pediatric dermatologist in Toronto at the Hospital for Sick Children. Dr. Mulholland is a pediatric ophthalmologist at the BC Children's Hospital in Vancouver. This podcast is a continuation of a previous podcast on the topic of sun protection. If you haven't had the chance to listen to that podcast, we recommend you have a listen. After listening to this podcast, we expect the learner to be able to generate a differential diagnosis for pigmented lesions on the skin and eye, discuss the key features of common pigmented cutaneous and ocular lesions, describe how cutaneous and ocular melanoma can present in pediatric populations, and list the treatment options for ocular and cutaneous melanoma. There was no financial support or any conflicts of interest for the development of this podcast. First, we'd like to present a case. You're now a fourth-year medical student doing a pediatrics elective. Your first patient is Lucy, who you saw last year. Now, she's 17 years old, presenting with a pigmented skin lesion on her right eyelid, and she is accompanied by her mother. Upon further history, Lucy had the lesion since birth, when it was barely noticeable. Until about 3 to 4 years ago, the skin lesion had been gradually increasing in size and darkened from light brown to dark brown, with no change in border or shape of the lesion. There is no bleeding or ulceration of the lesion. When asked about any other spots she's worried about, Lucy pointed to the brown lesion on her right conjunctiva. She said it was present at birth and she noticed some darkening from light brown to dark brown as well. It is small and she didn't notice appreciable size changes. She's otherwise completely asymptomatic and denies any eye discharge, blurry vision, foreign body sensation, or pain. Lucy is otherwise healthy and family history are unremarkable with no known melanoma. She never had any severe or blistery sunburns. She does not drink alcohol or use recreational drugs. Her allergies include peanuts and pollen. On examination, her skin is pale. On the right lower eyelid margin slightly lateral to the medial canthus, there's an approximately 4 by 3 mm symmetric dark brown and oval-shaped papule with irregular but well-demarcated borders. Similarly, there's a well-circumscribed dark brown 1 by 1 mm limbal lesion at the 9 o'clock position on the right eye. There are no lesions visible on objectophthalmoscopy. Her visions are 20/20 bilaterally. What could these lesions be? Are we worried about them? Could they be melanoma? From the physician's perspective, the biggest fear with sun exposure and pigmented lesions is the occurrence of malignant melanoma. However, it is reassuring that the vast majority of pigmented lesions in children are actually benign and monitoring would be the safe option. Next, we will discuss how to recognize those benign lesions, then we will talk about malignant melanoma.
A very common pigmented lesion present at birth is congenital melanocytic nevi, which is a benign proliferation of melanocytes. It is important to keep in mind that small CMN may be initially noticed by the caregivers sometimes later during the first year of life. CMN can present as macular, papular, or mixed lesions, and can vary in color substantially. Hair may or may not be present. The lesions tend to become more prominent and typically grow in size proportional to the child's growth. It is crucial to be aware that proliferative nodules can occasionally arise in the lesion in young children and may be mistaken for melanoma. CMN is classified by its largest diameter. Small CMN are less than 1.5 cm, medium if between 1.5 to 20 cm, large when measuring 20 to 40 cm, and giant if they measure over 40 cm. For large and giant CMN, there may be satellite nevi that may be scattered on the skin and can be in areas distant from the main nevus. For smaller CMN, the risk of melanoma is low and virtually none after puberty. The rate of melanoma is 2 to 2.5% for large CMN and 3.1% for giant CMN. These melanomas are called congenital melanocytic nevus associated melanoma. Nevi that tend to appear after the first 6 months of life are called acquired nevi. They can have a wide range of clinical presentation, but most commonly they are symmetric, round to oval shape, evenly pigmented with sharp and regular outlines with a homogeneous surface. They are usually less than 6 mm in diameter, and they sometimes can have perifollicular hypopigmentation or pigmentary stippling. The number and size of acquired nevi can increase in number and size during childhood and adolescence, peaking in the third decade and slowly regressing with age afterwards. A subtype of acquired nevi are called atypical nevi. Atypical nevi often have a particular morphology of slightly larger size with a less distinct border and often more prominent center with less prominent periphery. It is important to understand that atypical nevi are not pre-melanoma, but markers for increased risk of developing melanoma. One single atypical nevus increases the risk of melanoma by 1.5 times. Having 5 of them increase the risk by approximately 6 times. There are some more rare types of acquired nevi that you should be familiar with. Spitz nevus, formerly known as benign juvenile melanoma, is a distinct subtype of melanocytic nevus, usually occurring on the face. It usually presents as a pigmented or pink, smooth-surfaced, hairless, dome-shaped papule or nodule with sharp demarcation. It is symmetric and the usual size is from 0.6 to 1 cm in diameter. If the lesion has one or more atypical features, is of larger size, more than 1 cm, irregular borders, irregular topography, or ulceration, they are called atypical Spitz nevus. In general, those with clinically unusual, changing, or concerning features should be biopsied. The last acquired nevi of note is a reed nevus. It tends to be seen more often in children and presents as a symmetric dark brown to dark papule, most commonly on the extremity. As the lesion grows, it can develop the classic starburst pattern, which refers to the central blue-black pigmentation with regular radial projections at the periphery. Later on, those radial projections may disappear, and their color can become lighter. The lesion may even completely involute. It is considered as a benign lesion. Melanoma is rare in children, representing 1 to 4% of all melanomas, but the incidence is increasing at estimated 1 to 4% per year. 79% of pediatric cases are diagnosed between 15 to 19 years of age. Pediatric melanoma often has atypical clinical presentations, particularly in prepubertal children. Melanoma may present as a symmetric, pigmented lesion with regular border or as a reddish-pink symmetric dome-shaped papule. It is very different from what we see in adults. One prominent clinical feature of pediatric melanoma is lesion evolution with rapid growth. Patients or caregivers may report bleeding or ulceration of the lesions, and patients may experience discomfort, pain, or pruritus. There are 3 main types of melanoma in the pediatric population. The first is conventional melanoma, mostly occurring among adolescents, which is associated with UV-damaged mutations. Spitz melanomas are predominantly seen in pre-adolescent children. They share some features with atypical Spitz nevus, and it can be difficult to differentiate them clinically, pathologically, and genetically. Later on, we will discuss about some of the tools you can use to differentiate melanomas versus non-melanomas. Approximately 50 to 65% of melanomas arise in a pre-existing nevus. This includes the last type, congenital melanocytic nevus associated melanoma, as we discussed earlier in the podcast. There are a few conditions more commonly in the pediatric population that you should be familiar with, and they should be differentiated from melanoma. They are vascular lesions, particularly pyogenic granulomas, blue nevus, cafe au lait macules, which can be confused with nevi, but usually are not with melanoma. Some vascular lesions, for example angiokeratoderma and thrombosed lymphangioma, can look black, hence mimic melanoma, but they're actually not pigmented. Pyogenic granuloma, also known as lobular capillary hemangioma, is an acquired vascular tumor of the skin and mucous membranes that can bleed, simulating amelanotic melanoma. They typically present as a bright red to bright brown, raised, slightly pedunculated or sessile papular nodule. Next on the differential is blue nevus, which is a heterogeneous group of congenital and more often acquired melanocytic benign tumors. The melanocytes are deeper in the dermis than other nevi, and it represents arrested melanocytic migration in which the melanoblasts remain in the dermis. They appear as blue-gray macules or papules because of the Tyndall effect, which is selective absorption of longer wavelength components of light by melanin, with reflection of the shorter blue components. Cafe au lait macules are flat pigmented lesions that may be present at birth or appear during early childhood, and are more prominent after sun exposure. They represent localized areas of increased melanogenesis. The size can range from a few millimeters to over 15 centimeters in size, and then they can enlarge in proportion to the growth of the child. The color may vary from tan to dark brown and are usually uniform in color, but a few darker macules may appear within the lesions. Cafe au lait lesions can rarely be associated with neurocutaneous syndrome, such as neurofibromatosis type 1 and McComb-Albright syndrome. In terms of assessment tools, we have the conventional ABCDE criteria, which stands for asymmetry, border irregularity, color variegation, larger diameter over 6 mm, and evoluting lesions. Given the atypical presentation of melanoma in children, the pediatric ABCD and CUP criteria were developed and can be used, and they stand for amelanotic, bleeding bump, color uniformity, de novo and any diameter, color pink or red, changing, ulceration upwards thickening, pyogenic granuloma-like lesions, pop-up of new lesions. The bottom line is to have high clinical suspicion for melanoma because the diagnosis can be challenging in children given its rarity and atypical presentation. If melanoma is suspected, refer to a clinician experienced in the management of pediatric pigmented lesions, such as a pediatric dermatologist, general dermatologist, or plastic surgeon is essential. An excisional biopsy deep to the subcutaneous tissue is needed to confirm histologic diagnosis.
Before we discuss pigmented ocular lesions, we'd like to acknowledge that they are a small fraction of ocular diseases that have been linked to UV radiation. Acute exposures due to the high-intensity sun exposure or arc welding can lead to photokeratitis. Over time, UV exposure can lead to droplet keratopathy, cataracts, pterygiums, and ocular malignancies. The Beaver Dam Eye Study, which examined the incidence of macular degeneration of 15 years, showed an association with childhood UV radiation exposure and the development of macular degeneration. Pigmented lesions can occur on a number of ocular structures, including the conjunctiva and uveal tract. A pigmented lesion on the conjunctiva could be a nevus, primary acquired melanosis, complexion-associated melanosis, or malignant melanoma. While this podcast is focused on anterior segment pigmented lesions, we will briefly discuss pigmented lesions of the posterior segment. The uveal tract consists of the choroid, ciliary body, and iris. A pigmented lesion of the uveal tract could be a nevus, Lisch nodule, melanocytoma, congenital hypertrophy of the retinal pigment epithelium, or melanoma. Patients should be asked when they first notice the lesion, any changes they have noticed with the lesion, their sun exposure history, and their personal and family history of any skin cancers. A thorough slit lamp exam by an ophthalmologist is important to characterize the lesion. The lesion's shape, color, size, thickness, and location are important in determining the diagnosis and prognosis. It's particularly important to evert the eyelids to ensure no lesions are missed. Additional tests, such as an optical coherence tomography, OCT, and ultrasound may be needed to further characterize the lesion, such as its depth. Nevi are common benign conjunctival lesions and are the most common conjunctival lesion. Just like skin nevi, conjunctival nevi may be junctional, compound, or subepithelial. On examination, they are mobile over the sclera and appear cystic, with well-circumscribed margins. Typically, they are unilateral at the interpalpebral fissure and at the limbus. Their color can range from pale yellow to dark brown. They're relatively stable throughout life, but may darken with puberty or pregnancy, giving the appearance of growth. If the nevus is stable, it should be monitored every 6 to 12 months, and photographs should be taken at each point. More frequent examination is required if the nevus is changing. Enlargement, color changes, or increases in vascularity should prompt evaluation and possible removal. Each nevus carries a less than 1% chance of evolving into melanoma. Primary acquired melanosis is most common in fair-skinned, middle-aged or older patients, and very uncommon in young patients. It appears as a flat, unilateral patch of yellow to brown pigment. On exam, they are flat, diffuse, and not well circumscribed. Typically, they are unilateral and may have a waxing and waning nature of their size and pigment. Small lesions less than 2 clock hours should receive yearly follow-up. Concerning features including increased nodularity, vascularity, and thickening, for which a full excisional resection should be done. Larger lesions and lesions with a cellular atypia require wide excision with cryotherapy with a 45 mm margin. Mitomycin C is often used as adjuvant chemotherapy. Depending on the cellular atypia, up to 50% may evolve into melanoma. Complexion-associated melanosis, CAM, also known as racial melanosis, is a benign lesion in people with deeper skin colors. It's most common around the limbus and appears flat and non-cystic on exam. It is often bilateral and increases with age. While CAM does not become melanoma, people with deeper skin colors are not immune to melanoma and should have yearly surveillance. Malignant melanoma of the conjunctiva may arise de novo from a nevus or from primary acquired melanosis. It is most common at the limbus, though non-limbal lesions such as those in the caruncle, tarsus, and fornix carry a worse prognosis. It often appears as an elevated lesion with vascularity. Lisch nodules are small, well-defined nodules in patients with neurofibromatosis 1. They usually become apparent by age 5. Approximately 85% of uveal melanomas are within the choroid posterior to the equator of the globe, while the rest occur within the anterior segment, iris, and ciliary body. Uveal nevi usually appear as flat or elevated lesions with variable pigment, and they should be observed lifelong with photographs. Iris freckles are superficial lesions that have no elevation or distortion. They're typically non-progressive, though malignant transformation is possible and rare. Uveal melanomas appear as pigmented or non-pigmented lesions. They typically present during adolescence. Iris melanomas usually at least 3 mm in diameter and 1 mm thick, and usually in the inferior half of the iris and associated with blood vessels. The pigment is often variable and the tumor progresses slowly. Most advanced tumors are treated with enucleation, while radiotherapy and local excision may be used for smaller, less advanced tumors. Other possible lesions include melanocytoma of the optic nerve, which is a darkly pigmented congenital tumor over at least part of the optic nerve. It occurs with equal frequency across all races. In addition, congenital hypertrophy of the retinal pigment epithelium are typically flat, well circumscribed, and pigmented. Sometimes within the lesion are depigmented lacunae with pale halos. It may be solitary or grouped in a bare tracks pattern. 4 or more of these lesions in a patient is linked to adenomatous polyposis of the colon or Gardner syndrome. Malignant transformation of CHRPE lesions have been reported previously. Similar to adults, the first-line treatment for pediatric melanoma is a wide local excision to the deep fascia. The margin size of excision is less defined in pediatric patients, but mostly depends on the depth of invasion and the location of the tumor. Lymphatic mapping and sentinel lymph node biopsy are controversial in pediatric melanoma, and the clinical decision should be made on a case-by-case basis. Adjuvant therapy has been used for localized disease with high risk of metastases and systemic therapy for advanced melanoma. However, the data is very limited regarding their efficacy. Conjunctival lesions that appear suspicious for ocular melanoma require an incisional biopsy to prevent tumor seeding. Once melanoma is confirmed, excision with a dry, no-touch technique and a 4 to 6 mm margin is the standard of practice. Afterwards, a double cycle of cryotherapy is applied to the margins, and alcohol is used to debride abnormal corneal tissues. Sclerotomy may be needed when the lesion involves underlying sclera. A 4 to 6 tumor-free margin is required. For melanomas greater than 2 mm or with high-risk features, sentinel lymph node biopsy is needed. De novo melanomas have the worst prognosis, and local recurrence is quite common. Uveal melanomas have historically been treated with enucleation, though recent advancements have now allowed treatment with proton beam or plaque brachytherapy to be reasonably effective. However, vision loss or decreased vision continue to be side effects.
Now we have reviewed pigmented lesions. Let's go back to the case to see what we would recommend for our patient Lucy. To recap, Lucy is a 17-year-old girl who presents with a 4x3 mm symmetric oval-shaped papule with irregular but well-demarcated border on her right lower eyelid and a 1x1 mm darkly pigmented cystic lesion on the right temporal conjunctiva at the limbus. There are no lesions on direct ophthalmoscopy. For the skin lesion, it was present at birth and had been gradually increasing in size until about 3 to 4 years ago, with no change in border or shape of the lesion. Otherwise asymptomatic. As you may already guessed, the skin lesion described is most likely congenital melanocytic nevus. Most congenital melanocytic nevi have irregular borders, as in the case for Lucy. However, it is important to know that the irregular border might be a concerning feature for an unacquired nevus. So you should always confirm if a pigmented lesion has present at birth. For Lucy's skin lesion, its increasing pigmentation and size proportional to her growth until the end of puberty is a part of its natural course. The pediatric ABCD and CUP criteria are negative for the lesion. The risk of melanoma in the future is also low given its size. Similarly, the eye lesions was also present at birth, with some noticeable hyperpigmentation with no change in size. Based on the history and physical examination, the most likely diagnosis is also congenital melanocytic nevus. The risk of ocular melanoma is low, but you should carefully photograph the lesion and book a 6 to 12 month follow-up appointment. You refer Lucy to an ophthalmologist for a comprehensive eye examination to ensure there are no other lesions involving the anterior and posterior segments of the eye. You counsel the patient on continuing to use sun protection and return if there are concerning features, such as bleeding, ulceration, pain, and so on. Lucy and her mother are grateful for your expertise and thank you for your time.
We hope you found our podcast helpful and learned something new. Here's some quick take-home messages for you. Pigmented lesions on the eye and skin should be observed carefully and biopsied if there are high-risk features or changes. Pediatric melanoma is rare and can have atypical presentations, especially in prepubertal children. The pediatric ABCD and CUP criteria should be used clinically for skin lesions. A thorough eye exam with photographs should be performed by an ophthalmologist to characterize each lesion and ensure there are no other concerning eye lesions. This concludes our discussion. Thank you for listening to PedsCases podcasts.
Check out www.PedsCases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes store, share with your friends and colleagues, or think about getting involved.